Hi, I'm Haley Palmer, your host of Fast Metabolism Matters. And today we're going to take on a topic that's very near and dear to my heart, which is autoimmunity. I'm bringing in Dr. Marc Kesselman. He's a rheumatologist at the Kiran C. Patel College of Osteopathic Medicine. We've worked together on cases, and at the Institute of Neuroimmune Medicine, we collaborate a lot on what's going on with this big surge in autoimmunity. He covered things like estrogen dominance in women, why the X chromosome, the second X chromosome that we carry, makes us more susceptible, things that we can do to prevent it, labs to run, how we can make our body more resilient or tolerant if we've been diagnosed with an autoimmune disorder. This was a great episode, you guys, and as always, you asked some incredible questions. So hold on, let's get ready. Let's have Dr. Kesselman come talk to us about autoimmunity. Today, I have Dr. Marc Kesselman back with us. Dr. Kesselman, your episode that we did had so many views, and what I noticed was there were so many people that had so many questions. And so thank you so much for coming back, because I would like to just kind of run through and see if we can help people get anchored a little bit about autoimmunity, what it is, what it means to our bodies. But thank you so much for being here with us. I know you're crazy busy.
Well, thank you. Thank you, Haley, and your team. I certainly appreciate the opportunity to speak with you and your audience again. Autoimmunity is a complex issue. It's probably one of the hardest courses in medical school for medical students. So it's not unusual for it to be a topic of great interest. So it's my pleasure to be here and discuss and explain whatever I can.
Yeah, and you mentioned medical school. It's evolving so much. I mean, we were in the international conference for autoimmunity, and I could not believe how many new ideas were coming into play. And I think long COVID is bringing that up too. We've kind of had this quick trajectory into, oh no, what do we do when the immune system? The immune system. I mean, just talking about the immune system has been really exciting. I wanted to ask. Why are we seeing, there's some statistics going around. Some people say it's 80% women, but why are we seeing a disproportionate amount of autoimmunity in women?
That's a good question. I think that there's a lot of reasons for that. Traditionally, autoimmune diseases have been more common in women, and it's mainly because of estrogen. Estrogen is a modulator. It's a hormone that modulates immune function, and it enhances immune reactivity, which means that it can be an accelerator of immune activity. So hormonal fluctuations, which occur during different diseases and also natural situations like puberty or pregnancy, menopause, can influence the onset and also the severity. So because of different fluctuations in estrogen and also testosterone in men, there are different situations that are aggravated and can become more severe. The other part is that we know that women genetically have two X chromosomes, and many of the immune-related genes are located on the X chromosome. You know, there's a kind of a genetic tendency as well. Now, there are some autoimmune conditions that are specifically that have a little bit male dominance, like ankylosing spondylitis. But the majority, the rest of the autoimmune diseases are more estrogen based. Women generally mount a stronger immune response than males, which helps fight infection, but also increases the risk of autoimmunity. So it's certainly complex.
And so like when women go through menopause and some of their E2s drop and the E1 elevates, that's even more inflammatory, right? Than E2. It doesn't modulate as easily.
Absolutely, and that's a great point. And one of the things we also see is when menopause starts hitting at that stage, a woman's risk of other diseases become equal to a man's risk. So, for example, at menopause, as estrogen starts falling, the risk of coronary disease starts increasing.
Wow.
the risk of osteoporosis and bone diseases start increasing. So at that vital age in the 50s or whenever menopause starts hitting, it's really important to be aware as a physician and talking to a patient, talking to a female patient, that the woman's risks of certain diseases can start increasing or being equal to a man's of the same age. They don't have that hormonal protection that they did when they were younger.
I love that you use the term hormonal protection. We have so many people that talk to in our community. We talk a lot about hormone replacement therapy. We talk about, autoimmune diseases. And one of the things that I just really, really try to stress in our community is when you start having your annual checkup to add autoimmune screening in there.
Mhm.
Because the earlier, there is so much, and we'll talk about that. There's so much that you can do from a nutrition perspective, from stress reduction perspective, from looking at your overall health and wellness. But if you don't know that it's there, then you don't maybe feel as compelled to make those positive lifestyle modifications. What labs would we add in if we were going to start, suggesting, and so I suggest in my community that we add that as part of your annual physical? Is it just an ANA, or what do you like to see when you're screening for autoimmunity?
It's a good question, and I just will jump in on a hormonal replacement. I think
Yeah.
that a hormonal replacement is a whole nother issue, and I think we as a medical community may have gotten it wrong that we have stopped the use of hormonal replacement, and it was stopped for such a long period of time because of risks of cardiac disease, of
Right,
cancers, and now when we look at it,
right.
we know that there's a tremendous benefit in continuing hormone therapy after a woman reaches menopause because of its positive effects on bone health, positive effects on general health itself. But that's another issue that we can talk about at some point.
No, I want to, I love that you brought that up, because so many times when an individual is doing hormone replacement therapy, I'm like, let's make sure we do an autoimmune screen, because they are so cohesive in how they impact the body, and vice versa. I always tell people that are doing, have been diagnosed with an autoimmune disorder, let's make sure we're looking at a complete sex hormone profile. Let's make sure we're looking at sex hormone binding globulin. Let's make sure that that's balancing the body so that it can be less reactive and less pro-inflammatory. I love that you brought that to the forefront. What labs do you love to see? Like, I'm going to prepare a patient for coming into you. What would be your dream that I had all ready for you?
Okay, so in screening labs to look at autoimmunity, there is a lab test called an ANA, anti-nuclear antibody. It's basically a broad screening test for connective tissue disease. So, for example, if we wanted to test the entire population of the world on whether there was any evidence of
Right.
autoimmunity, we would want a sensitive test that would give us some idea of the degree of autoimmunity in the total population. That's an ANA, anti-nuclear antibody. If we knew the percentage of patients that have some degree of autoimmunity, and we would want to drill down further, then we could go to extensive testing specifically to look for the degree of lupus or the degree of Sjogren's or other connective tissue diseases. But as a general screening test, an ANA is an excellent general screening test to see, is there some degree of autoimmunity?
And
Now,
oh,
oh,
go
go
ahead.
ahead.
No, is there a difference between the ANA titer and the sedimentation or the sed rate?
Yes, yes. So there's a difference. So the ANA will give you a titer, and generally it goes from a low titer of something called 1 to 40. That's the lowest that is recorded. It can go lower in certain sensitive testing that's done in certain places in the country. But a titer of 1 to 40 is the lowest titer that it could be, and then it doubles from there to 1 to 80, to 1 to 160, 1 to 320, and so forth. The higher the titer, the more significant that titer and that test is. So somebody that has a rather low titer, maybe 1 to 40, 1 to 80, may have early evidence of some autoimmunity, or may be on the threshold, or may just be in the general population of patients that has a positive test without any evidence. But as that titer doubles and triples and quadruples, and if we get a titer of 1 to 640, for example, the strength of that is that the statistics show that there's more of a there's a higher chance of some degree of autoimmunity and something we can pinpoint it at that higher level. So the higher the titer, the more significant that titer is. That is separate from the sedimentation rate, which is really a marker of inflammation. So the sed rate or ESR, erythrocyte sedimentation rate, basically it's in a red blood cell. And the C-reactive protein, they're both one of the liver markers. Those are markers of inflammation only. So those don't tell us about whether there's autoimmunity, but it tells us, is there inflammation going on in the body?
So the body can have an inflammatory response, but not be in an autoimmune. Can I take it back and explain to us what does it actually mean to be positive for an autoimmune disorder? What is that? What's happening in the body?
That's a great question, Haley. One very important part of this is what does autoimmune reactions and what is autoimmunity? Autoimmunity means literally the body fighting itself. So what happens is the term that we use in immunology or in rheumatology is what's called loss of tolerance. You think of it as a pool table, and on the pool table are all just red pool table balls, okay? All of a sudden, one of those balls turns blue. Out of 100 balls on a pool table, one turns blue. And all the other red balls say, hey, how are you? Everything's great. We're glad to have you here. You look different than us, but we're okay. Everything's great. Well, now all of a sudden, that blue ball starts getting very antsy, and he starts bumping into all the other balls, and now he's causing a problem. He or she or they are causing a problem. Now there's a loss of tolerance. All the other red balls say, hey, you're different. We have to react differently. So there's a loss of tolerance. It's a loss of tolerance of change or difference from the other cells. And that's what happens as a result of autoimmunity. One of the cells changes in the body, and it changes to the point that the other cells don't accept it as one of their own anymore. And when that happens, the immune system gets activated and starts saying, hey, there's some type of loss of tolerance here. Is this a bad actor? And if they sense that it is, it starts creating antibodies or defenders to try to defend the other cells and the body against this bad actor. And when one of the antibodies that they create is this ANA, anti-nuclear antibody. So it's actually a defender to defend itself from other bad actors. And that can occur, for example, COVID came to us and we didn't have any memory of it, and we didn't have any antibodies, and that's why we recommended widespread vaccinations. But COVID is a virus, and when a virus comes to us, we do the same type of evaluation. Are you bad or good? If it's bad, we start saying, okay, we need to create a defender, and we try to create antibodies against this outside influence. In autoimmunity, we're creating antibodies against an internal self-generated threat.
When we were in Cambridge this year, there were a variety of different international scientists presenting, and a couple of them were talking. I love that you brought up COVID. We're talking that possibly we're looking at long COVID having an autoimmune character. I'll use that for. What are they saying in the rheumatology world? Are they embracing that theory? Are we pondering it? Do we feel like we've got some data around it?
Also, excellent question. So the answer to that is, from the rheumatology community, we're very much aware that COVID, of this virus, and in some instances the vaccination as well, may have caused the body to start creating these autoantibodies. And we have seen in patients that have had COVID 1 time, 2 times, 3 times, also vaccinations, that there are a lot of new antibodies that have been created. So
Right.
there's definitely a risk that these antibodies may generate some degree of autoimmunity. We don't know yet because we need the longevity studies and longitudinal studies to kind of see where these go. In a lot of patients, the autoantibodies are just sitting there. They're not reactive yet. They're the red pool balls are not reacting to the blue one, not yet. But there's always that potential. And the only way we know is to put these patients on surveillance. So yes, I think we're very much aware that this is a potential. We don't know where it's going yet.
Right. It's been, I hate to say fascinating, but it's been fascinating to watch because I think it's really made us all think about what is causing such a surge in autoimmunity. You mentioned that sometimes a virus can trigger it. Like we've seen a lot of Epstein-Barr virus. Are they correlating that with things like MS or other potential autoimmune things? What can trigger autoimmunity? What makes the cell change and us attack ourselves?
That's a great question, and I think we're going to continue to ask ourselves that. There are several different potential triggers, and we don't know all of them. We know that genetics plays a big role, and certainly there are certain genetic attributes and certain genetic markers that show that patients are vulnerable to autoimmune events. We know that in lupus, we know that in rheumatoid arthritis, there are certain genetic profiles that are definitely found in patients that have certain autoimmune diseases. We
So
know that.
do they have more of a tendency? So it's like an epigenetic perspective, something turns it on?
Yes, so they
Okay.
have that genetic tendency, but they need more than that for that autoimmune reaction to occur. And again, let me just take a step back. The what even if you have autoantibodies or you have a genetic tendency or you have an abnormal bacteria or a virus in your system, you need kind of a multiple of reactions to occur and
Complex.
lightning to hit. And then all of a sudden, lightning hits that cell, that one cell, and starts that trigger from going on. And once that trigger is activated, it starts causing a lot of inflammation going elsewhere and everywhere else in the body. Up until that point, a patient can have a genetic vulnerability, a patient can have autoantibodies, a patient can have abnormal bacteria, but not go into that autoimmune response until that one situation that triggers it to start becoming active and causing inflammation.
So we did family testing because I have an autoimmune disorder. You and I have talked about it a lot. Every time I get Dr. Kesselman to myself, I'm like, what about this? But so we did do some screening on both of my son and my daughter both. And that predisposition is definitely evident with both of them. And so yeah, I'm 31 years in clinical practice of nutrition. I'm now a research scientist in neuroimmunology, finishing my PhD. All of that to be said that I try to be a stickler with their nutrition because I think that that's one of the most powerful things that we can do to prevent, cool off, like on all facets, all aspects of it. And you and I've had a lot of conversation about that. There's a few triggers that we had a great conversation about, which was gluten in the diet. And I love the way that you have explained that to me. And I was hoping that you could kind of talk to our community about that. I think sometimes they think I'm just the gluten police or a buzzkill but it's really important when we're talking about autoimmunity and inflammatory perspectives.
Absolutely. Gluten is a major cause of symptoms in patients. There is a disease called celiac disease,
Yes.
which is really a true autoimmune disorder, and it's triggered by gluten. It occurs in a small percentage of the population, but I see it in a large percentage in my rheumatological population of patients who are gluten sensitive. there is gluten sensitivity that's non-celiac based. So there's what's called non-wheat, non-gluten sensitivity, and those situations exist as well. So a patient may test negative for celiac disease, but still have a gluten sensitive behavior. Some people feel better on a gluten reduced diet. It's without a doubt, whether they test positive or negative. Sometimes when patients are placed on a gluten-free diet, they just feel better. Even though their blood doesn't show that they have a true gluten sensitivity, they're not celiac positive, but they feel better. And there are patients that don't need to be on gluten free diets. I think that it's all trial by elimination,
Right.
diets, and seeing what patients are sensitive to, seeing what diets aggravate disease. And I think I tell all my patients, make a diary. If you wake up the next morning and you don't feel well, what did you eat the day before? Put that down. And it's not worth getting sick over. There are multiple foods to eat that are delicious. It's
Yes.
wonderful. But don't force yourself, because sometimes when we see people that continue to force themselves to say, I'm going to eat the gluten, they get worse and worse. And then all of a sudden it triggers acute flares of their inflammation. So
Okay.
that's the end result.
Once a person has, yeah, and we're big on rotating your foods, right? Not eating the same thing every day.
Right.
And I am from my autoimmune, gluten, soy, wheat, dairy, and corn free. We find in the animal population that those are all what we use for a pro-inflammatory weight gain is what we say when we are formulating feed. We want to
Hmm.
trigger the certain hormones that create, adipocytes and stuff like that. So from me, from an autoimmune perspective, that's like no, like those are just out. And then, but then the rotating's so important. We're seeing people, and I was where they've been maybe diagnosed with lupus and then or celiac, but then they start stacking the autoimmune receptivities or testing. Do they truly have, multiple autoimmune disorders, or is the testing just becoming sensitive because they're in that pro autoimmune inflammatory perspective? I've heard debate on that.
Yeah, sure. That's a really good question. The answer to that is, when you have one autoimmune disease, it makes you more vulnerable to others. I
Okay.
see patients who generally they may have lupus, but they also may have a mixed connective tissue picture as well, where a patient may have two competing autoimmune conditions, and generally one is more dominant than the other. One has more symptoms, so we end up treating the more dominant situation. But a patient can have celiac disease. A patient can have a skin disease called vitiligo, which
Hmm.
is another autoimmune skin disease, a thyroid condition, and also have rheumatoid arthritis, or also have lupus or Sjogren's. So it's common to see one autoimmune condition and a secondary autoimmune condition. In fact, the way I was trained is we should always watch out for that second autoimmune condition to develop.
I had a client that had really low, like 1 to 40 ratio ANA titers, but she had dermographia, right, where we could write on her arm. And then she got a tick bite. But we had checked her for celiac several times because she did have that gluten sensitivity. And I know that there's
Mhm.
more testing now, but she got a tick bite. She got really sick. And then her ANA titers went to 640. And
Oh,
she developed dermatomyositis. And what was crazy was then, boom, she popped positive for celiac. I mean, it was just like, and there was just maybe the scenario was the table was set, or what happens in situations like that?
Well, that's a good example of one situation where you have an acute inflammatory response. Dermatomyositis, for your audience, is derm is the skin and myo is muscle. So the breakdown of the word. So it's a skin and muscle inflammatory disease. It is prevalent in children. It's prevalent in adults, and it is generally it's an active systemic cause of inflammation. Once there's systemic inflammation, it breaks down the barriers in the body for opportunistic other infections and also autoimmune diseases to kind of sneak in there and start setting up shop. So once a patient has one condition, which is an acute muscle skin inflammation, other inflammatory and autoimmune conditions can certainly pop up because of the vulnerability that is now made by the primary autoimmune condition.
I love that. Well, I was so lucky. I was young when I was diagnosed with ITP, the autoimmune disorder that I have. And I
Mhm.
had the best hematologist at UCLA who, really said to me that, control your stress, control your nutrition, right? And set your environment up that's conducive to you staying out of an inflammatory period. Like, so then I went and got in a car accident. But I worked so hard. It's always my focus is I say, okay, the best thing that I can do is not insult my body with things that can trigger other autoimmune disorders, balance my nutrition, and then, stress reduction. And it's been, for me, I've had wild success. My platelets are normal. I don't take any medication anymore. I've worked really hard. But he really set me down and said, "Don't take this lightly. Like this is a turning point." I'd been accepted into vet school, and I took a medical leave of absence, and I honestly feel like it was because he was honest with me and candid that, this is a turning point in your life, and you can either live an incredibly, healthy life and get control of this, or you can continue to eat, Funyuns and grape soda. And I just dated myself. And it's just a slippery slope, and it's not going to a good place. So how do you help clients kind of embrace or feel empowered? Because I mean, to leave vet school, maybe people would think that was tragic, but for me, it was like this massive shift in, I mean, this obviously this 31-year journey, this massive shift in empowering myself to have control over my health destiny. So and your patients love you. How do you work with them so that they feel like, look, they've gotten this diagnosis, and now how do I take control and empower myself?
Well, thank you. First of all, I think what you've done in your journey is just absolutely amazing, and I really applaud how you've handled it. When I talk to patients and I manage patients, um, making them feel empowered that they do have a chance on their own to try to help themselves, I think is very important. Cutting out specific environmental triggers, for example, smoking or being away from high-powered lines, radiation lines, or any type of pollution. Cold weather sometimes can be a trigger. I think those are very important. And you stressed the nutritional part. I really believe that nutrition plays a big role in helping people deal with their autoimmune diseases. Now, again, my lupus patients are very fragile. They could do everything right, and then somehow the body just changes even overnight, and they can go from a stable situation today, and tomorrow can wind up in the emergency room. So a lot of these patients are dancing on a razor's edge as far as stability. But I think that being on a good diet, eating healthy, exercising, being spiritual and getting good relief from that, and stress reduction, I think all of that plays a big role in keeping people at the best that they can be, and also having good contact with their physician. And again, I think I may have stressed this earlier, that if they don't feel well, don't hide it. Don't try to say it's going to get better. Let somebody know, so somebody can evaluate and say, okay, this is okay, you're doing fine. This was just a little blip, or I need to do something else with you, with your medications, or with something else before it turns into something catastrophic.
And I love what you do where you look at what the immune system's doing when they're having an autoimmune flare so that then you can, it's almost like you reverse engineer to tailor their body specifically. And I encourage everybody, if you're working with a rheumatologist that's not Dr. Kesselman, to really look at when you do have a flare, go in, get your labs run, look at your CK, look at homocysteine. I mean, we look at TNF alpha, we look at IL-1, we look at a lot of different immune markers because we want to understand what is your body in a flare doing and how can we possibly support that flame, to stay nice and low and not stimulate a reaction. You said something to me about smoking, radiation line pollution, cold weather. Where do you land on alcohol? Every so often, I've never tolerated alcohol well. I've always wondered kind of why, and apparently, but genetically, neither of my kids do. They both called me during college and complained about that. But every once in a while, I'm like, okay, I'll have a glass of wine, and I just boom, inflammation. I mean, and I've tested like every allergy you can think of for alcohol because I think if I could wrap my head around that and not blame it on my autoimmunity. But how do you fall? What do you see with your patients with that consumption?
Um, another good question. What I see with my patients is an intolerance to alcohol, a general intolerance to alcohol. And even though, from the American College of Cardiology, for a while, we were recommending maybe one or two drinks a week, more of a red wine because of the anthocyanidins and the colorful aspects that's creating antioxidation in the body. But now we also know by current literature and current data that there's a relationship to cancer
Yeah,
with alcohol. So, and one of the other aspects in rheumatology is we use medications that could be directly affected by alcohol. Patients who are on Tylenol, and you take a Tylenol, and then all of a sudden you combine that with alcohol, and that starts causing significant liver dysfunction. There's a medicine that we use in rheumatology called methotrexate, which is one of the most common medicines that we use for the treatment of rheumatoid arthritis and other diseases. Putting that together with alcohol can cause significant liver dysfunction and elevation of liver tests and hepatic dysfunction. So in general, I think that alcohol is a bad actor. And can trigger autoimmune events. It can trigger, now we know it triggers cancer.
right.
There was this idea that maybe it's beneficial for patients with heart disease because of the French studies that showed that they drink lots of alcohol and they are a lower incidence of heart disease. But we know that that has not been proven true with patients who have autoimmune diseases as well.
I appreciate that. And it's so funny because it's literally like every, I don't know, couple, 3 years or something, and I'll be like, I think I can have that.
Well,
That
that's it.
little that little person sitting right here says, just try it again. And then I mean literally, like I can't get my rings off and my body hurts and I just go, okay, keep my, we have some great questions from our community. I want to ask one more on the psychological spiritual aspect of it. We talk a lot about what we call fear of the flare, right? In our world, in our community. And and I'll tell you, like, so with ITP, that I have a clotting, and maybe you can describe it better, but I mean, I was moving a ton of furniture, and I mean, I literally, banged and dropped, and I ended up with a bruise on my leg. And I had to talk myself off a cliff. I said, it's okay. And what I do is I've got an open order with my rheumatologist again, who has been my rheumatologist for 30, almost 30 years. But he just lets me test my platelets and my ANAs and whatever I want, whenever I want, because he says emotionally it's good for me, right?
Mhm.
So, big gnarly bruise, and I know exactly what I did. But when my ITP was in full flare, I would bruise. I mean, I could count 20 bruises on my leg and 14 on my arm, and my gums would bleed. Um, and so I did. I just, after this many years, I ran in and, let's look at my platelets. Let me look at my uh I look at my liver values, and let me look at my ANA titers. Everything was pretty, but how do you help people that have just waiting for that other shoe to drop? How do you counsel people in that?
It is. There's a definite nervousness and anxiety. Once people have finished their flare, will they develop another one? I think trying to give people a sense of confidence that yes, you may develop a flare, and let people know that there's a good potential that another flare could develop, but we have to have a plan on how to treat it. Your rheumatologist is saying, go get your labs checked, you'll be able to see your platelets, so you get immediate understanding
Feedback, yeah.
of that. And in that situation, we know that for example, in ITP and something called autoimmune thrombocytopenia, where patients are developing antibodies to the platelets or
Yeah.
antibodies to the white blood cells. So the platelet count drops and the white blood cell count drops, and you start feeling poorly in those situations. The most important thing is to understand that try to understand the flare and the timeline so that you're able to be aware of kind of the flare aura. And we call it migraine aura, where a lot of patients with
Mhm.
migraines, they kind of know that they're going to get a migraine. They get this aura that, oh my goodness, let me go take my medicine, my shot, whatever, to try to prevent that migraine from accelerating and going catastrophic. In autoimmune diseases, there is a slight aura or a slight uh, pre flare condition that people will notice that they start developing. And if they're aware of that, they may be able to either take medications, contact their healthcare provider, or do something that it may not progress more than it is at that point.
I,
And I think making people more self-aware is really super important.
whenever this has been my coping mechanism, when I have fear of the flare, um, use the fear as I have three things. I go stop, take 2 minutes. Sometimes I'll go in if we're in the clinic, if we're at Einem and it's crazy, I'll run into the bathroom or whatever, and I just go, okay, Haley, these are my three things. How is your sleep? And I sleep like it's a medication. I mean, I focus on the priority of sleep as if it's a life-saving medication. Like I equate it to something that would, you know, an ambulance that would pick me up from a car accident. Like it's that important for me, for my to keep me out of flare. I say, how's your food? And again, my triggers are corn, wheat, dairy, soy, coffee, and alcohol. And then I say, like, just assess where are you around your triggers? And we had people that were at our home that were staying at our home. And one thing that hits me really hard is any of the perethrins. So any like Raid or bug spray, which I have none of that in my home. But I always just do like an assessment. And we had a person that was at the barn that had brought in a different kind of horsefly spray. And I'm like, okay, like I always just say it's time to clean house, like make sure my environment is conducive to me staying healthy. And so those are kind of my three things. It's like, are you, sleep catches up to me. What are you putting in your body and consuming? And then what are potential environmental triggers? And then the fear of the flare, I try to think of it as this like, it's time to check in. It's just time to check in. It's time to check in and say, what's going on. Because all of that data that's coming in, your body peripherally knows, like you're not eating right or you didn't get enough sleep. And so I think it kind of elevates that cortisol a little bit and says, razor, you're on the razor, get off the razor. That's been really helpful for me.
Absolutely. I think recognizing people who go through flares will recognize when they're in one. They may have certain complaints. For example, if you have an autoimmune blood condition, you're going to feel weak and tired, and you're like just a complete general change from your normal behavior. Some patients will have joint swelling where they'll see their hands are tight. They can't move, open and close their hands, or they'll get swelling in elbows or arms. Some people get bruising, like you described, those bruises that will just start popping up. They'll wake up one morning and all of a sudden see, 5 or 6 bruises, and they know that they didn't have any traumatic or any accident that it could have caused it. So I think recognizing where the flare is, and then having the plan. Do they have medications? And I know, do they have prednisone or steroid available just in case? Did they take their medicines as they were supposed to? Do they have medicines on board? Are they eating right? Is there something that they may have eaten the day before that they said, oh my goodness, now I know I shouldn't eat that again? And generally making sure that they're hemodynamically stable, that they can keep going, or do they feel like I need to reach out to somebody because I don't want to get worse? I'm concerned that there may be some issue that I may not be able to function appropriately. So I think, making sure that people have that ability to say, look, I need to reach out to somebody, or I need to go to the emergency room myself. That's really, really important.
Yeah, and it's so interesting that you said that. It was another real pivot point for me. Once I felt like I started getting things under control, and it wasn't just this wild, out of control feeling, which I spent a big chunk of time in the hospital, with different kinds of options that I had to sort through. IV chemotherapeutics. I was on 60 to 80 milligrams of prednisone. And then I lost a big function in my right kidney. That didn't go very well. But I was a surgical tech in the vet space, so it was easy to, stay on prednisone. It felt good. I felt amazing. But I wasn't testing my body. And then I started going down and I started feeling better. And I remember Dr. Arzu, my hematologist, he was like, Haley, we need to check you and monitor you. And I'm like, I'm good, leave me alone. Because I just wanted out of, but this is the pivot part for me where I said, okay, be empowered, don't be afraid. I ended up hemorrhaging with an ovarian cyst that ruptured.
Oh,
And
goodness.
ITP, I know. And I got to the hospital, my platelets were 53. So they were like, and I'm like, I don't want a transfusion. But it was that at that moment I said, okay, it's one thing to bury your head in the sand. And that was when he and I, like, we had a big kind of coming to Jesus moment medically, where he said, I understand that you didn't tolerate prednisone well. I understand. I mean, I tried, I was on methotrexate. I tried Cellsup was really hard on me. I tolerated Imurin better, but I just didn't, I had so many, it was so hard for me. He said, I understand that, but we have to create a protocol for progress for you. You can't just be without, and then I get a call that you're hemorrhaging in the hospital. That's like, this doesn't work very well. So that's when we started to, test things regularly. In the beginning, fortunately, I worked in a clinic, so I was able to test them every 4 times a year, but we usually recommend twice a year, to look at, and everybody's autoimmune markers are different, right? Like with my client that had dermatomyositis, her autolase was a really nice marker. Her autolase and her CK was a really nice marker as we were getting her back into a state of better homeostasis and health. And we did use hormone replacement therapy as this collaborative care. But everybody's markers are different. How often do you like to see your patients, even if they're doing pretty good? Do you see them annually, twice a year? What should people be advocating for?
So I think that patients with autoimmune disease, active autoimmune disease, should be seen, every 3 to 4 months,
I agree.
and check labs. We don't need to check always all the labs at every 3 to 4 months, but we need to check inflammatory markers. We need to check liver function. We need to check blood count, platelets. Those are things that are standard every 3 to 4 months, and especially if patients are on medications like methotrexate or prednisone or hydroxychloroquine or biologics, making sure that we follow those blood counts on a very regular basis. And if they have a flare, check them then too. So if there is a flare, it's important to check those inflammatory markers and see where they are, because it could be lower than what we want, and that may require some emergent response from our part. So checking markers very important. There, as you pointed out, different autoimmune diseases require different markers to be checked. In dermatomyositis, looking at the aldolase and CK, which are muscle enzymes, are very, very important because it's directly related. Remember, skin and muscle. So that's extremely important. Patients also with dermatomyositis have a higher risk of cancer. So we want to make sure that they get age-appropriate cancer screens. So I think, that's why being in touch with your rheumatologist, with your healthcare provider is very important. And I am the first person aware that being in the medical environment, you're vulnerable, and not all the times is it as conducive as you'd like. You don't get as much time as you like. The billing and the paperwork and the logistics sometimes could be a nightmare. But I think with an autoimmune condition and with the conditions, it's real important to find that environment that's going to be good for you. And you may need to just go from one person to another until you really feel comfortable with a healthcare provider-patient relationship.
I love that you gave us permission to do that, because I think so many times, people underestimate that partnership. And for me, obviously, I consider you in my partnership as well now, but I'm so grateful for that. And I do recognize that I've done a lot of hard work, but I've had a team that has been so supportive of my crazy ideas, and science-based ideas, and, Hail Mary ideas, and they've helped me navigate through that process.
Hey, this is Haley Pomeroy, and right now we're going to transition into our Q&A portion of the podcast. And you'll notice that we have live viewers asking us questions. They're my Fast Metabolism members, and they get all kinds of amazing benefits, like member discounts on my world-class supplements and shakes, every product, every day, personalized guidance and support from myself and my team, and even the ability to ask questions of our podcast guests. If you have questions and want to get them answered, you should absolutely join my membership. And if you go to haleypomeroy.com/member, you can join for free for 30 days. Again, that's haleypomeroy.com/member, and join for free for 30 days. I can't wait to see you there.
I have community members that have been listening to our podcast that have some questions for you, Dr. Kesselman, and
Sure.
I'm going to read a couple of them. If you're watching this on delay and you're not here live with us, please go ahead and post comments below. We will get to those for sure, and we'll definitely have Dr. Kesselman back. But if you're fortunate enough to watch us, let me give you a couple questions. So, Dr. Kesselman, one of our listeners asked, when you say autoimmune is and they said, is it estrogen based, or is estrogen a catalyst for, does it make an autoimmune more impacted in the body, or how does that work? Can you revisit that just a little bit?
Sure. Is it a catalyst? Yes. Is it estrogen based? Yes. So I'm going to say to both answers, yes. And that's why we see so many autoimmune diseases predominantly in women. It acts as a catalyst. We know that sometimes extra estrogen can cause autoimmune reactions in the body. But we also know that because of the estrogen relationship and the hormonal flux in the body, it can aggravate an underlying condition. It has positive, we know that estrogen has positive effects. It has positive effects on cardiovascular health and bone health, but it can make a woman more vulnerable to autoimmune dysfunction. And again, we feel it's probably related to the genetic influence on the X chromosome. I think that's really what we're looking at from a genetic point of view. So, the answer is yes. And women are more have a higher prevalence of autoimmune reactions. We're seeing more women who have developed COVID have developed more autoimmune reactions. Okay, that too. So it's one of those situations that in certain disease states we see a higher incidence in the female population.
Yeah, Great. And another great question is if there were three things that you would suggest a person today do to prevent going into an autoimmune disorder, what three things would you suggest to do to prevent getting an autoimmune?
Wow, that's a great question. Um,
I love them.
so I guess the first one would be eating healthy.
Okay.
I think changing your diet to a healthy, whether it's Mediterranean, low sugar, low red meat, ideal plant-based, of course, a type of diet. That's the most important thing, and eliminating triggers that may have caused dysfunction in your body previously. Number two, would be getting plenty of exercise, and exercise based on your age, and as we know 30 minutes at age 25 is good, but 90 minutes at age 50 is kind of equal. So making sure that you get plenty of exercise,
So you're
and
saying we need more exercise as we age?
as we age, we do, because our
Oh, I love that.
metabolism slows down over
Yeah.
time. So the 30 minutes that you have for exercise that keeps you and maintains your weight and your metabolism at age 25, now at age 50 is probably almost between 60 to 90 minutes. And as you get even older, it goes from 90 minutes is probably necessary to maintain that. Plus, if you have other anti-metabolism type of diseases like thyroid disease or hypothyroid conditions, that also can blunt your exercise responses, or medications that can do it. So we need more exercise to maintain ourselves
Love
as
that.
we get older. And I guess the third one I would say is have a good relationship with your healthcare provider, such that you can talk about disease prevention. And I think that's very, very important. Vaccinations, if that's what's necessary. Staying away from people who are obviously sick. Stop smoking. Be careful about being next to any environmental triggers. And it's also I guess a degree of luck as well. We don't have the full answer, and with full transparency, I wish I could say that all those three are going to be guarantees, but we don't have the
Right.
full answer as to what would create an autoimmune condition. Sometimes you can do all of that and still end up with an autoimmune condition. So I don't want anybody to think that those are the three holy grails, but those will help.
Those will help. Yeah, and that's everything we can do, right? Is I always tell our community, I'm like, look, we're all aging, we're all sunsetting. And so if you feel better today than you did yesterday, you've actually made this massive leap in the right direction. So it's the same thing with the prevention. And our other community member just asked if they were just recently diagnosed with an autoimmune disorder, and it looks like they just had a positive ANA titer. What would be the next thing that they should do from a screening perspective?
Okay, so if somebody tests positive for an ANA, and that's generally one of the most common consultations that a rheumatologist would get. When I see a patient referred for a positive ANA, I take an extensive history, and what I do is try to listen to see, are there any um, uh, aspects of their health, their symptoms, that would lead me down one lane or another? Or do I hear symptoms of rheumatoid arthritis? Do I hear symptoms of lupus? Do I hear symptoms of Sjogren's or scleroderma? If I do, then I know which area to pursue. But if I have a patient that says they have a positive ANA, but they're relatively healthy, they don't have any obvious symptoms, or some of the symptoms are really not specific, then they could fit into several categories. Number one, they could fit into a category of patients that have positive ANAs, but have no immediate autoimmune component to their disease at this point. Number two, they can fit into a population of patients that may develop autoimmune disease or symptoms 15 years down the road, as we know. Those patients I place in surveillance of potential symptoms that may develop, and recheck the labs on an every 6-month basis for a couple of cycles. And number three, those patients with ANA, they may have a relationship to something, whether it's autoimmune disease, whether it's cancer, hopefully not, whether it's thyroid disease or some other cause of the positive ANA. So when when a patient has a positive ANA, they need to go through this kind of agenda of, is there any symptoms attached to it? Is there anything else that I could say that could cause the positive ANA? Do we need to start treatment because I see something, or should I continue surveillance over time? And I do a couple of cycles of every 6 months and then go to every year if I don't see anything develop. Remember, there was this really great article that came out late 90s, early 2000s, showing that sometimes patients with a positive ANA may develop symptom 1 15 to 20 years later. So those patients I place in surveillance, and we just have to watch and see if they do develop something, and whether or not that does develop at all. So I think it fits into one of those categories.
A couple community members, actually, I'm going to condense a couple questions. They were asking about environmental exposures. What are the biggest exposure points that make autoimmune worse? What if we look left, right, all around our personal environment? What are some things that we can look for to eliminate?
Well, cigarette smoke, I would say, is probably the number one environmental risk factor. It's the number one environmental risk factor for rheumatoid arthritis. It's a bad actor. We have done a great job by eliminating it from airplanes and from restaurants mostly, but we still walk around and not only do we smell cigarette smoke, but you'll smell marijuana smoke and all of that. So I think that the smoke itself, if you can eliminate that or be away from that, I think that's extremely important. We also have car exhausts, which has been shown even now to affect climate situations. So I think air pollution in general, I think, is a big factor as far as toxins and exposure. Some things we can't even control, because you want to run on the street, you want to run in the fresh air, and you're kind of exposed to some of that. Heavy metals, I think, are probably a big component. We know that mercury and amalgams that dentists use for a long time may have caused a certain amount of disease. There are plastics, the BPAs and the plastics that we've seen, and the microplastics, which are now, we're seeing it in everything. I mean, right. I can't. I read every morning my cardiology, rheumatology, general medical articles, and I see inevitably microplastics in some food group or some foods that I can't believe. Medications and infections, I think those are probably the last couple.
Okay. So even over-the-counter medications too, right? I mean,
yes.
When we are doing, so we do self-assessment questionnaire. And one of the things, people think some of the questions are so funny, but I think because I've been screened for autoimmunity so many times, but it's like the dry eyes, blinking, the mouth. We do even salivary pH testing, where we're just looking at like little hints that the body can give us to give us some direction. But it's always shocking to me how individuals, even if they haven't been diagnosed with autoimmunity in general, but are autoimmune group, how casually over-the-counter medications are taken. Like I just go, the cold, the flu, the allergy, and they can have such an impact. Like I get that, I don't know, somebody deemed them as okay, but they're not benign.
No, not at all. Our access to medications has increased over time, and I think that's a direct cause of multiple allergies and symptoms that patients can develop. And again, they're finding every day you see one of these over-the-counter medications. I think recently eye drops were found to have some abnormal elements in it, and now just recently we see that the protein powders have lead in it. So I think that you just have to be very careful. You have to be aware about what is out there. Be careful, and just because it's over the counter doesn't mean that it's safe or good for you. Even though the FDA said these medications can be over the counter, it doesn't mean that they're good, and there certainly doesn't mean that it's good long term. I'll just bring one case an example. Proton pump inhibitors, the Protonix and the Nexium and the Prilosec, when it first came out, these medicines, which are great for reflux and esophageal reflux, when they first came out, they were only meant for 2 weeks.
Yeah.
And then if it doesn't work in 2 weeks, you need to contact your GI provider. That's the way it came out. Immediately.
Yeah.
Immediately. Okay. Now we see people that are on these medicines for years, and how much it has decreased absorption of certain elements in their gut, and bone loss, and electrolyte, and things that are not absorbed well. So just because it's over the counter doesn't mean it's good to take long term.
And not to mention that it's with the histamine blockers. I mean, I love that the Treg cells, the Nobel Prize winners, the three scientists, because I'm a Treg fanatic. Yeah. And I'm like, what about these histamine blockers over the counter? I just got all up in arms about that. And I love that you mentioned the protein powders, because, we third party test everything. And I cannot tell you how many times lead, arsenic. I mean, it's so prevalent, and it breaks my heart when it's something that you're like investing in to stay healthy. When you talked about a lot of the things that they study and they research, one of the things when I got into more of the research science space, that I'm almost severely traumatized about, which is the majority of the medications that are tested are the exclusion. One of the first exclusion factors in this population that they test is anybody that has an autoimmune disorder. So I'm going to say that in maybe a better way. So when a lot of the medications, if you've been diagnosed with autoimmune, talk to your rheumatologist, especially if you're on any kind of pharmacological plan or supplement plan. Because some of the stuff that's over the counter, when they study the population to say that it's safe, when you say the FDA says it's safe, the exclusion factor of said people that they can try, one of the exclusion factors is no people that have been diagnosed with an autoimmune disorder. So it should have a big warning label. Like I started going through like all the cold and medications and all those things. They're so contraindicated with somebody that has an autoimmunity. But instead of saying like it caused people with autoimmunity problem, they just don't test it. I don't know. I was actually, Dr. Speth brought that up for me when we were in pharmacology ethics. And I wanted to shake him and say, do you hear what you just said? Because there's so many people diagnosed with autoimmunity, and they think they can just, pop into the store like the rest of the population and take something. And it's really a slippery slope. So tight relationship with your doctor, a pharmacist, look at the pharmacology of stuff, because this whole disease is dysregulation. And so anything that's going to make your body less stable or less sturdy, less hardy, right, is going to add an impact. So
absolutely. And I'll mention loss of tolerance. Anything that's going to make your body have a less tolerant view than it did before. And I agree. The reason a lot of medications were approved, and they wanted to get them approved, so they eliminated a large percentage of the population, which is autoimmune disease. So it's very true. Also, looking at medicines at an older age, they excluded older age patients. So we really have no guidance in patients who are over 70, 75 years old as to really what to recommend. So that's very important. And to always ask, if you have a question, ask your rheumatologist, ask your healthcare provider, all of that.
So Dr. Kesselman, I can't thank you enough for being here. And one of the reasons why I want to do this live for our community is because our goal is to help them be prepared, right? Not have fear of the flare, have an empowered feeling, but understand what's going on in their body, and also effectively communicate and understand that, look, a partnership is critical in this situation. And if you don't feel, loved up, supported, encouraged, egged on, cherished by your practitioner, there are phenomenal doctors like Dr. Kesselman that make their patients feel that way. And I love getting to talk to you, but I will tell you one thing I enjoy more is getting to talk to your patients, because the way they speak of you is with such adoration. It's not even, I mean, there's the academic respect, obviously, but it's adoration for having the compassion that you do for your patients. So I can't thank you enough for doing that on behalf of all of us autoimmune people.
Well, thank you. I feel very humbled, and I certainly appreciate the nice, kind comments. And I will tell you that your show and your education of your patients is instrumental in making people healthier and ability to accommodate their diseases. And that it's okay to have a flare, okay to be sick, but know how to deal with it and learn how to deal with it. And it really, your show is just amazing at being able to help orient people as to what to do and to be a good soldier in being able to handle their complaints. So I really applaud your efforts. And again, it's my pleasure, and I feel really humbled at your comments.
Well, thank you. And it was a very lonely time when I was going through it, and I promised myself, okay, I'll let vet school go away, but what my life's work is going to be is to make sure that no one ever feels hopeless and feels alone in this process, because it wasn't fun. So I'm trying. So we will have you back. Our community is good. We're gonna have a lot of questions, you guys. I promise we'll get them all answered. Thank you for being here, everyone. And Dr. Kesselman, again, thank you so much.
Thank you. It's my pleasure. Thank you so much, Haley, for the opportunity.
Bye-bye.
Bye-bye.